Thank you. And good morning and welcome to the joint CERS-KRS Retiree Health Plan Committee for September the 5th, 2023. At this time, I'd like to call the meeting to order. And Mr. Board, could you read our opening legal statement?
Certainly. For the record, I want to note this is a regular meeting of the joint CERS and KRS Retiree Health Plan Committee. This meeting is being broadcast via video teleconference pursuant to the Kentucky Revised Statute Section 61.826 and may be viewed by the public at the Kentucky Public Pensions Authority offices located at 1260 Louisville Road in Frankfort, Kentucky. It is also being broadcast to the public via Facebook. I ask if you are speaking and are not appearing by video, please identify yourself before talking. In the event the video or audio broadcast is interrupted, we will attempt to reestablish a connection. If a connection cannot be reestablished within 30 minutes, the meeting will be adjourned and rescheduled to another date. Thank you.
Thank you, sir. Ms. Rankin, roll call, please.
Yes, sir. Mr. Powell?
Here.
Mr. Fulkerson?
Here.
Dr. Miller?
Here.
And Mr. Piercy?
Here.
Thank you.
Thank you. And I understand we have public comment this morning, if you wouldn't mind reading that also.
Yes, sir. Our public comment today comes from Larry Totten, and he writes as follows. The Humana section of the meeting materials for today's meeting contains a veritable cafeteria of options for possible enhanced benefits. I note that the Humana rate for the 2024 will be rising to just under the contractually allowed 5% to $93.35. One can assume that the same will apply for the 2025 to put the rate in the neighborhood of $98. These rates are substantially lower than the contribution rate of $252.51. It would seem that the addition of benefits totaling no more than $10 per month per member would be very doable for our insurance plans. 4 of the 5 were 100 plus % funded in June of 2022. The assets in these plans gained 9.5% as of June 2023. This increase should still be manageable even with assumed increases in plan rates for 2026 and beyond. I don't presume to know what those covered under the Medicare Advantage plan would like to see added. I would ask, though, that a final decision on the benefit structure be delayed until the October 23, 2023 meeting to solicit input from the members to find out. At a time when pension benefits have stagnated for 12 years, this is something that KPPA can do for its Medicare Advantage members. Thank you.
Thank you. That being our only public comment, we'll move on. Has everyone had a chance to review the minutes for our last meeting? And if doing so, have you found any corrections, additions, deletions that need to be included? Hearing none, I will now entertain a motion to accept those. And first,
I'll second.
thank you, Dr. Miller. I have first and second. Any discussion? Hearing none, all in favor of approving the minutes as written, say aye.
Aye.
Opposed? Motion carries. Next will be the establishment of the 2024 healthcare component and health rate insurance. Ms. Pettyjohn, I believe you're up for this.
Mr. Powell, I'll just step in here. Ms. Pettyjohn had to be out unexpectedly all week last week. Many thanks to Abby Sutherland, the Assistant Director in Retiree Healthcare, and Ashley Gabbard for helping me pull all of these together.
Connie's on.
She is.
Okay.
Like I said, she had to be out all last week, so I'm going to do the lion's share of this presentation today. I'm sure I won't be able to do it as well as Connie would, but she's here to help me if I miss anything or say anything incorrectly, or if there's questions, she's certainly on here to help with those things. So, but I will do most of it today. So,
Thank you.
all right, thanks. If you go to the next page, Sherry, this is just talking about the 1994 Kentucky CARES Standard Plan, which says that basically that an insurance plan must be provided by the state employees that contain the same benefits as provided under the Kentucky CARES Standard as of January 1st, 1994. So I'll just let you know, again, we were filling in for Connie last week. There are some dates on here that reflect 2023. Those should say 2024. After the meeting's over, we'll update these and we can get the material on the website corrected. So for 2024, the Living Well CDHP option has a relative value that is equal to that of the 1994 Kentucky Care Plans. And Sherry, that's on the next page if you'll just go down. So there is a plan that has a relative value of that meets the 1994 Kentucky Care Standard. Going to the next page, the plans that are offered by the Kentucky Employees Health Plan, or KEEP, have not changed this year. They still have the Living Well PPO plan, which is the contribution plan that the Health Plan Committee has suggested for the monthly contribution rate for several years. But this plan the member pays co-pays for their medical and prescriptions. There is no HRA with this plan, and it has a relative value of 0.98. Again, none of the plan design has changed from last year. If you'll go to the next page, Sherry. The next plan is the Living Well CDHP plan, the one that I just mentioned that has the relative value of 1.02. This has an embedded HRA plan. It has a little higher deductible than the PPO plan, and it is the cost to the member are based on co-insurance instead of the co-pays that are set by the plan. And the next page, Sherry, the Living Well CDHP, basic CDHP plan that also has an HRA is offered, and it has a lower HRA amount. It's $250 as compared to the CDHP plan, which is $500, higher deductible and higher maximum out of pocket than the CDHP. This plan has a relative value of 0.98 as well. It's 0.97. That was last year's relative value, so we'll update that as well for the materials. Any questions about those plans? Connie, did you have anything additional that you wanted to add?
No, not at this time. Thank you.
Okay. All right, hearing no questions, let's go to the next page, Sherry. The default plan. The default plan for DEI is remaining the same as it was last year, and that was the Living Well Basic CDHP plan without the HRA. So this default plan is for new retirees who do not elect to enroll in a health insurance plan or do not complete the waiver election. They will be automatically defaulted into a plan if the committee continues to do that. And the recommendation is to use the same plan that the KEEP plan is using, which is the Living Well Basic CDHP without the HRA, which was the default plan for last year. Any questions on that? Okay, next slide, Sherry. Then the next thing that we'll talk about is the tobacco usage. Now this KEEP plan includes a tobacco usage fee, and it applies to single level of coverage. So if the member is a tobacco user, then a $40 tobacco fee would be assessed. If they are on a couple, parent plus, or family coverage, then there's a maximum of $80 that would be charged for tobacco usage. So, and it applies to all individuals on the plan who are age 18 years or older. So the committee will further down decide whether or not to charge that tobacco usage fee as they have in the past. Going on to the next page, Sherry, the Living Well Promise. We wanted to spend a little more time on the Living Well Promise today. There's been some questions recently around this Living Well Promise, so we just wanted to give a little more information on it. The Living Well Promise is a part of the KEEP plan design, and it is a part of their overall wellness program. By completing the Living Well Promise, the member can access the best benefit options, learn about their health status and history, and learn about and understand their health risk and take actions to get and stay healthy. So as part of this plan design, the KEEP plan asks that this information be completed each year, and it enables members to take part in their overall well-being, which leads to lower costs to the plan. Now, a failure to complete the Living Well Promise during 2024 plan year would result in the member not receiving the $480 premium incentive, or $40 a month. So that means if these members do not complete the Living Well Promise, that the individuals will pay $40 a month towards their premium. The members must complete the online assessment. It is an online assessment, and that needs to be completed between January 1st, 2024 and July 1st, 2024 to receive the premium incentive. If a member is unable to fulfill the Living Well Promise because of a physical or mental health condition, KEEP will work with them to develop an alternative way to qualify for the Living Well plan. Only the plan holder is required to complete the Living Well Promise. So if there's a family plan, then not every individual on the plan would have to do that, just the plan holder, except in the case where a cross-reference occurs. And that cross-reference is where two retirees or an active employee and a retiree could cross-reference their plans to receive a better a premium payment. So in that case, each plan holder would need to complete the Living Well Promise.
One thing,
Yes, sir.
one of the changes for this year is that it's just the online health assessment. Previously, they had the in-person clinics where someone could go and actually have a physical exam. This year, that's not available. It's only going to be online. But if anybody should have any issues, that's part of that. They can contact our retiree health, and they will assist them in making that online assessment available and completed, and work with anyone that would have any issues. So that is one slight change this year to that to the DEI, or Department of Employee Insurance, that has brought forth.
Great. Thank you for that, Mr. Powell.
Certainly.
And then if we go to the next slide, Sherry, we just wanted to highlight some of the places where we notify our retirees that they do have to complete this Living Well Promise. For any individual or for any retiree who is going to be on the KEEP plan, we send a new retiree KEEP insurance book. It is included, that information is included in there. Of course, we always include it in our annual KEEP open enrollment materials. I believe, Connie, correct me if I'm wrong, we have it on the front cover to say that this must be completed.
Yes.
Okay, great. It's also on our website under our insurance or non-Medicare eligible insurance page. We make social media posts for our members, reminders. Over half of our members are using the online retirement process. So they also, when they complete their enrollment online, it is specified there that that Living Well promise has to be completed to receive the premium incentive. And then we also send an email, a reminder email, out to any of our retirees who haven't completed the Living Well promise by June. They do receive an email notification from us reminding them that that has to be completed by July 1st. Any questions about that? Connie, anything else to add?
I have a question.
Oh, I'm sorry. Go ahead.
With regard to the tobacco, the personal responsibility if you're a tobacco user, is vaping considered in that?
Yes.
I know a lot of smokers that smoke cigarettes that then choose to vape don't consider themselves smokers. And so I didn't know if there were, I was reading the definitions and didn't see in there that vaping was specified. And so just a thought to maybe put into that I know that's splitting hairs, but when you don't define yourself as a smoker and a tobacco user, that might be something that we might need to consider.
Yes,
That's a very good point, Dr. Miller. And, it's tobacco use. It's not even smoking. It's tobacco use. So we just need to get DEI to look at that definition. That is their definition, and it's in their legal documents as a true, so they can enforce it. So we'll take that to them. Thank you.
Yeah. Dr. Miller, what you may not be aware, as for the non-Medicare eligible retirees, that they fall under the state health plan, and we have little control over what's implemented through that, other than our representation on the health insurance board. So anything like that has to go to the Department of Employee Insurance and for the health board of that. When we get to the Medicare eligible, that's where our contracts are with the KEEP plans. It's with the Department of Insurance.
I understand the bureaucracy. I work in it every day, but just a thought, because that's the world that that's kind of my world. And so I just thought I'd put that in someone's, if we haven't thought of that, that might be something that we just consider. So.
And we appreciate it, and we will, Connie attends meetings as well as myself, and so we'll bring it up at the next meeting for them to review for the next plan year. Appreciate the input.
okay. If there aren't any other questions, then we'll go on to the next page. Now this page is talks about the premiums for 2024. The actual premium amounts are set by the plan, are embargoed until I believe the middle of September. So we can't put actual amounts on here, but what DEI does allow us to do is give approximations using percentages. So what we have listed here are the 2023 premiums. Like I said, the Living Well PPO for 2023, that single contribution or that single premium amount was used to set the monthly contribution rate for the single level of coverage in 2023. And if you look down in the chart below that, that rate is going up approximately 14% for 2024. And then you can just look across the rows and see the percentages that those plans for each of the different levels are increasing. The Living Well CDHP, you can see that the premium amount was lower last year, but it is going up almost 14.5% in 2024. Any questions?
And I actually did the math on it, and the Living Well PPO is going to be the higher price plan again this year.
Yeah.
If you extrapolated those numbers.
Right. And we'll, like I said, in the middle of, I think it's the middle of September, Connie, that those will be released, the actual dollar amount.
Yes, they have to file them with the legislator and it has to be enacted. So they're not legal until then.
Right.
So yeah, we have to wait. Thank you.
Okay, any questions? Okay, well then let's go to the next slide. And then this slide is just basically showing the plan enrollments for each of the different plans available. We listed out at the top grid, it's those who are receiving 100%, the hazardous retirees with 100% contribution. Of course, most of our retirees are in the PPO plan because that is the contribution rate plan that's been set for several years. So just a little bit of information on numbers there. Any questions about that? Okay, then I think we're ready to go to the next slide, which contains the decision points that need to be made by the committee. We have those outlined here, and I can just, Mr. Powell, if you want me to, I can just walk through each of those. And then do you want to just roll it up into one motion for a vote after we've discussed each of them?
Probably ought to do each one because there's variables to each standard.
Okay.
Because you got the decisions for both the non-Medicare hazardous and non-hazardous. And so that gets a little complex through there.
Okay, then we can just look at those individually. So the first decision is to determine the 2024 percentage contribution plan. And like I said earlier, the current for 2023, that plan was the Living Well PPO plan.
Yeah. I thought it'd be, we just remain with that would be the standard Living Well PPO and use that rate as a contribution for the 240 months for both the hazardous and non-hazardous retirees. Anybody have any other thoughts? Any discussion on that? Keeping the same plan?
No, I'll make the motion, Jerry, if that's what you need.
Yes, sir. I'll need a motion in a second. So I have a motion for that and a second from Mr. Jim Toney. Any further discussion? Hearing none. I'll call for a vote to establish that the Living Well PPO plan will be the contribution rate for the hazardous and non-hazardous members. All in favor, say aye.
Aye.
Aye. Opposed? Motion carried. The second one we have is the contribution rate for the hazardous spouses, dependents. That would be the couples, families, and parent plus. I'd also recommend that we would set the contribution rate for the Living Well PPO for those appropriate subcategories for the spouses and dependents.
Yep, I'll make that motion.
Second.
I have a first.
I'll second.
I think I have a second. Any more discussion? Hearing none. All in favor, say aye.
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 Aye. Opposed? Motion carries. The third item would be the tobacco fee. Is there any objection for it remaining at 40, or is there anybody want to make a change to that?
I mean, that's the rate through KEEP, is it not?
It is.
Yes.
Okay, yeah. So I just make the motion. We follow KEEP's lead with those rates.
All right. Thank you, sir. Have a first
I'll second.
and a second. Any further discussion? All in favor say aye.
Aye.
Aye. Opposed? Motion carries. The next item is to allow the KPPA retirees to the customer-driven health plans, the CDHP, with the embedded HRA. Again, like I said, this is part of the KEEP benefit as established. So, any discussion? Any questions? I'll entertain a motion to accept the enrollment or participation for the HRA fund.
I'll make the motion.
Have a first
I'll second.
and a second. Any discussion? All in favor to allow that participation, say aye.
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 Aye. Opposed? Motion carries. Let's see, the next one is the retirees who failed to enroll in the KEEP plan that failed to submit the health insurance will be enrolled in which plan? It has been the basic plan. Yeah.
Mr. Powell, can I interrupt?
Yes.
I think
Sure.
that we, E and 1E, the Living Well promise needs to be voted on.
Oh, okay. Thank you for catching that. On the Living Well premium incentive, the incentive will not be applied to enrollments in the Living Well plan who failed to fill the Living Well promise in 2024. So, again, this is the standards that they use. Is there any questions about that?
I'll make a motion. We follow the KEEP rules for the Living Will promise.
All right, thank you, sir. I have first and then the second.
I'll second.
Thank you, ma'am. I have first and second discussion. Hearing none. All in favor, say aye.
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 Aye. Opposed? Motion carries. Let's see here. Where was I?
Number two.
The number 2A, new retirees who failed to submit a health insurance enrollment form will be filed into which plan? That was the Living Well Basic, I believe. Is that correct, Connie or
Yes.
Karen?
Without
Yeah.
HRA.
Yeah, well, the basic doesn't include the HRA. And that is the one that has the 0.97 compatibility. I will entertain a motion that we accept that as that the Living Well Basic be the default plan.
So moved.
Thank you, sir. And a second.
Second.
Thank you, ma'am. Any discussion? All in favor say aye.
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 Opposed? Motion carries. Retirees currently enrolled in the KEEP plan that fails to submit health insurance application be enrolled in to the same plan at the same level they had in 2023. Kind of like the easy enrollment. So if they take no action whatsoever, then they get to keep the same plan they had previously.
That's right, Mr. Powell. It's not a mandatory enrollment, so if you all decide that they can do that, then we'll just roll them into the same plan at the same level of coverage that they had for 2023.
Yeah. The word I was trying to look for, search for, was having trouble finding was passive enrollment.
That's it.
So it would be the passive enrollment that they keep the same plan. Any questions about that? We'll entertain a motion to accept that.
So moved.
Have first
Second.
and a second. Any discussion? All in favor for the passive enrollment, say aye.
Aye.
Aye. Opposed? Motion carries. Item number 3 is will allow for the cross-reference option for the retirees. You know that the cross-reference is where you have families with get the same issues or may work for the different agencies in the state or same one, and they can cross-reference each other. So any questions for that?
I'll make a motion.
Hearing
We
none.
allow cross-reference options, if I could talk.
Yeah, got your tongue tied around your eye teeth to see what you're saying. Thank you. And a second?
I'll second.
Thank you, ma'am. Any discussion? All in favor, say aye.
Aye.
Motion carries. Last one for this one is set the premium for the KEHP Medicare second payer plan. That's the ones where people have gone back to work and they're eligible to participate in the KEHP plan. For simplicity's sake, I thought it'd be good just to leave it as the Living Well PPO plan, as well as for the non-Medicare eligible.
And Mr. Powell, if I may just add a little bit of information, the premium for the Medicare secondary payer plan, like Mr. Powell said, it's the same as the PPO this year in 2023. It does, when the legislation took effect to allow these retirees to participate in this plan, the law said that it does allow for the premium to be rated separately from the rest of the plan. So far, it hasn't. It's new, and so the rate is still the same. They haven't done that yet, but I just wanted to make it clear that that could change in the future, where there's a different rate for this plan. But 2024, it'll be the same as the rate for the group.
And I like the idea of setting the rate separately from the non-Medicare and the Medicare eligibles. It's went back to work and affected by the Medicare second payer. Is that acceptable with everybody here to maintain the Living Well PPO plan as the benefit for those eligible in the Medicare second payer reemployment?
Yes, I'll make the motion.
All right, thank you, sir. And a second?
I'll second.
Thank you, ma'am. Any discussion? Hearing none. All in favor of accepting the KPPO, Living Well PPO plan for the Medicare second payer premium, say aye.
Aye.
Aye. Opposed? Motion carries. Let me see here. Looks like that's all we had for that section.
I think that covers it for all the decisions. The next two slides are just informational, so nothing to be discussed there. But I think that's it for the non-Medicare eligible group.
All right. Thank you then. Anything else before we move on? Okay, let's move on. Miss Tracy, I guess you're up.
Well, thank you. Good morning, everyone. Great to see everybody. I'm happy to be here with you today to share some information about the 2024 renewal and various other pieces of information. If we can go to the next slide. So this is the agenda for today. We'll present the 2024 renewal, show you the information related to that. We also have some benefit enhancement options for consideration. We'll review the Part D cost share changes for 2024, and then Larry will share an update on the Baptist Health Medical Group contract. We can go to the next slide. Actually, I think you can skip one more. All right, so as we get started, just wanted to refresh everybody's viewpoint on, what is incorporated into a renewal. So each year as we annually assess the rate increases that may be coming, or in some cases decreases, we do look at your PPO, your specific PPO medical claims cost trend. We review pharmacy benefit claims cost trend, CMS reimbursement changes. So keep in mind that, what we receive for your membership annually is adjusted from CMS. So that impacts the rate going forward. We consider any benefit changes that you may be making or that CMS may be requiring us to make, various other changes to things from CMS, and then of course the credibility weighting based on your specific member demographics and experience. Any questions on that? All right, we can move to the next slide. This is the rate increases that are set forth for 2024. So for the premium plan, so this is where we find the majority of your membership. Currently, we have about an average about 54,608 members on the plan. Current premium is $89.28, and the premium for 2024 will be $93.35. And you can see here, we're estimating that your membership will increase to about 55,613 on this plan, just based on prior year averages that we look at. So seeing an overall annual dollar amount increase of about $62,000 or $62 million. I wish it was 62,000 for you on the premium plan. Looking at the essential plan, which is a leaner plan, and also as a reminder here, the medical benefits on both of these plans are the same. The difference is in the structure of the pharmacy benefits. So for the essential plan, currently this year, there is a $0 premium on about 5,000 members. The proposed renewal rate for 2024 is $4.07, with an estimated 5,335 members for $260,000 in premium amount for the 2024 plan year. Overall, this is a little under a 5% rate increase, about 4.6% overall for your membership. So any questions on the renewal? All right. Included with the renewal, just want to touch base on these as well. These are financial commitments that Humana included in the 2023 RFP. They will continue into 2024. So we have a Humana rate. The rate includes a guaranteed maximum increase of 5% annually. So that will apply for the 2025 renewal year. We do have a gain share agreement included with the 2024 offer, and then also standard performance guarantees as we have had in the past. Next slide. All right, Humana also has membership. Your medical only and mirror plan members are on an ASO funded program through Humana. So with that plan, we provide you with an ASO fee, and you can see that the ASO fee per member per month in 2023 was $28.50. That is increasing to $29.88 or $29.88. The mirror plan also includes dental benefits. So a member who is on the mirror plan will have included with their plan A dental benefit, currently that is at $4.80. That will increase to $5.04. Also on the Mirror plan, the membership has the option to choose either the Essential Pharmacy Plan or the Premium Pharmacy Plan. So you can see here the corresponding rates for that. If they choose the Essential Plan, it's $36.18 for 2023. That increases to $40.25 for 2024. And then the premium plan is currently at $135.31, and that increases to $139.38. Questions on that? All right, can move on. So that encompasses the renewal rate changes with the current benefits as they are today. There are some, minor changes in the pharmacy plan mandated by CMS, but if you go with the current benefits as they are structured, that would be the premium rate. But when we met, I think it was back in April, and we reviewed the Plan Compass report with the board and the members of KPPA's administrative team. We were asked to consider some various benefit options that might actually, I think the statement was the most bang for the buck. So what benefits the members, but then would also potentially really long-term have a positive impact on your membership and your plan performance. So we worked with our folks internally, and we have some recommendations for you to consider. And then we also have, I think there's the vision, dental, and hearing benefits. We've got some things for you to look at on that as well. So if we can go to the next slide. So we've primarily focused on pharmacy benefit enhancements when thinking about how might we be able to really enhance the benefit for your members, improve their overall health outcomes, and ultimately have a positive improvement in the overall plan's performance. So a couple of things to look at here. We do have available a STARS generic medication adherence table that could be added to the pharmacy benefit that would allow for coverage for select generic medications from 3 STARS drug classes for medication adherence. Now, I'm sure you all are familiar, the STARS plan impacts the funding that we receive from CMS. So the better that we do and that your members do in compliance with a lot of these areas, that gives Humana potential to have a higher STARS impact, which then positively impacts our funding from CMS. So good connections here all across the board. This particular table would allow for a $0 copayment, which is less than the copayment on both of your plans for generic medications, for a 90-day supply on these diabetic, hypertension, and statin medications. Should you add this benefit to the plans, the premium on the premium plan would increase $2.51, and the essential plan would increase $3.99. Another option for you to consider is a preventative medication table. So this would be added also to the benefit, and it would have a $0 copayment per prescription for these items that you see listed here. So smoking cessation products, bowel prep products that are used for colonoscopy, generic statin medications, select breast cancer preventative medications, and select HIV medications. So again, looking to improve compliance, to ensure that members who need these medications, that there are no barriers to them receiving these medications for their care and treatment. To add this table to your pharmacy benefit, you would see for the premium plan, it would cost an additional 71 cents. For the essential plan, it would be an additional $1.09. So this would, you could add this for less, but I think if Humana were to recommend, we believe that the STARS generic medication would probably be the biggest bang for the buck of the two choices. And then there's also the option to include both of these benefits combined, adding both of those tables, and that would have a premium plan increase of $2.62 and an essential plan increase of $4.13.
Question?
Tracy, just to clarify, these items are already covered today on the plan. This would just enhance and basically eliminate the member cost share for the applicable items. So these items are all built into the plan today. It's just that the member's cost is higher than what is outlined here.
And the difference between the essential and the premium plan is because as the drug plan embedded in each of those plans, as the essential is not as good as the premium. So that's why that would be more to improve or to increase the benefit on the pharmacy side.
That is correct. Yeah, most of it. So the co-payment, actually it's a co-insurance. So that essential plan has a $435 deductible that is met first. And then they have a 25% co-insurance on all medications. So if you were to apply these tables that we call them to that benefit, the deductible would be waived and they would have first dollar 100% coverage basically on those medications. All right, if there's no questions on those, we can move to the next slide. So again, looking at some of the other, we've looked at these vision enhancement options in the past. I will say that, as we consulted with our folks here at Humana, asking again about bang for the buck, vision and hearing always come out, as something that should be considered. Clearly providing a benefit so that your membership has options to buy glasses and contacts and have their routine eye exams. We do believe that contributes to overall health, as does the opportunity to purchase hearing aids at reduced cost. So the current coverage for your members from a vision perspective, they have outpatient physician services for the diagnosis and treatment of disease and injury of the eye. So medical diagnoses, those are covered. For people with diabetes, they have screenings for diabetic retinopathy covered once per year by the plan. And then one pair of glasses or contact lenses after each cataract surgery is included. So anything related to really just vision, so vision care, eyeglasses for general vision challenges, issues, are currently not covered by the plan. So there are 3 varying options here based on cost. You can see various different. The first one has $175 combined maximum benefit, a 0 copayment for eye exam, 1 eye exam annually, and then would also include benefits for out of network. That would be an 80-cent per member per month increase to your plan. And then you could enhance that if you wanted to. The next one that's listed here is a 0 copayment for 1 eye exam, $100 combined maximum benefit per year for contact lenses, glasses, and frames, including various different levels of protection. $175 out-of-network benefit for the routine eye exam and coverage for glasses. And then the last one, which is the highest cost option, also $175 combined benefit out-of-network, 0 copayment for routine eye exams, 1 per year, $150 in-network for contact lenses, glasses, frames, etc. And that is the highest cost option there. So any questions about the vision options? All right, we can look at the hearing options. Again, we've provided 3 options for you to consider. The first has 0 copayment for a routine hearing exam once per year, and then a maximum benefit of $500 each year for hearing aids of all types, and up to 1 per year, $500 for each hearing aid annually. The second option has a 0 copayment for routine hearing exams up to 1 per year, and a $1,000 maximum benefit for hearing aids, and 1 ear per year. Sorry, getting tongue-tied here. Coverage amount for each hearing aid up to 1 per year. And then the last one is a $1,500 maximum. It includes that routine hearing exam as well. And you can see the amounts there go up accordingly. questions on that? On the hearing aids, if we can go to the next slide, I did want to note that currently there are over-the-counter hearing aid benefits available to your members. So they do have an opportunity to purchase through a company that Humana works with called True Hearing Solutions, discounted over-the-counter hearing aids. Should you enhance your benefit offering to cover hearing aids, that benefit allowance would not be applicable to these over-the-counter benefits. So these over-the-counter benefits are available without a prescription, and the benefit enhancement you could add would be for prescription-only hearing aids. All right, next up is dental. So you currently do offer an enhanced dental benefit to your retirees. The medical coverage is specific to medical conditions. That is inclusive in the medical benefit. It includes surgery to jaw and related structure, extraction of teeth to prepare for perhaps radiation or neoplastic disease treatment. And then the supplemental coverage that you began offering a few years ago, I'm sure you recall, is $1,000 maximum benefit per year with 100% coverage, 1 per year of the bite wing x-rays, 1 oral exam, and 1 cleaning. And then you have 100% coverage once a year or once every 3 years for an oral evaluation and periodontal exam, with a 50% coverage limit, 1 per year for fillings. And that's up to that maximum of $1,000 annually. So looking at the benefit enhancements that we're providing, next slide. So everything you see here increases the cleanings and the exam coverage to 2 per year, which is a typical benefit or a typical standard care pattern treatment for members. It increases the number of fillings that can be filled. It includes extractions. And then you can see there's an option to keep the benefit maximum at 1,000, but adding an opportunity to have more cleanings and treatment. Or you could increase the benefit maximum also to 2,000. So if you keep the maximum at the same, but change the items that they can receive for that maximum annual benefit, that's a $4.73 increase. And then the $2,000 maximum takes it up to $5.50 on the dental plan. All right, and I think the last benefit enhancement we have to share today, we had also been asked to consider on the plan, if you wanted to, the medical plan portion, you could reduce the copay or the deductible as it is structured today. So several years ago, the deductible was set at $320. You increased that to $500. It's probably been 4 or 5 years ago now. But if you wanted to reset the deductible that members have to reach on the medical plan before the plan pays for various services, the impact of that for $400 would be an additional $7.40. And then to go to a $320 deductible back to where it was several years ago would be an additional $13.45 per member per month. So that summarizes the various different items that we have offered for your consideration today. I don't know if you want to have discussion about that or if you'd like us to go on the next part of the agenda is the Part D cost share changes.
Looks like Mr. Piercy has a question.
Sure.
I've done rough math on this using your projected numbers, and it appears to me that for every $5 of premium increase, it adds better than $3.3 million in annual spending. Would you agree with that?
Based on the membership? Yeah, that sounds about right.
Okay. So going back to the public comment we heard when the meeting started, so $10 would add better than $6.6 million of spending from the trust, added to about what, 3.7 million in premium increase from last year to this year. Does that sound about right?
The premium increase,
Okay,
so
we're
from 58 million up to 62 million.
right. So we're talking to do what the public comment suggested, adding $10+ million in spending between premiums and benefit enhancements, and the majority of that would be the benefit enhancements. Would you agree with that?
Yeah, I mean, I haven't done the exact math, but yes, I think that seems logical.
Okay, all right, thank you.
Just a comment that I would add is all of these benefit options, you know, are pure, they're options. And if there's a different option that maybe comes to mind, we could certainly take that back and price that essentially. But these are benefit factors. So, you know, when you lower the deductible by $100, you know, you can see the pricing impact there, for example. I mean, that's simply a actuarially derived number there. So there's I mean, that's how it comes about. You're expecting virtually a 1-for-1, impact on the member cost share for whatever the reduced benefit or enhanced benefit is in this case. So, but if there's something else that you all would like us to consider, we're certainly happy to do that.
Is there any benefit that somebody would like to throw out for the Humana team to look at and review?
No, and just for clarification, Jerry, I was just trying to combine the public comment with the presentation to point out that, you know, all these things come at a cost, and those costs aren't small when you start talking about $10 million from one year to the next.
Yeah. I will come back to here in a minute we can discuss if who's interested or not interested in the benefits a little later in this section. So,
Okay, we can go to the next slide then. Actually, you can go 2 ahead. We'll talk about the Part D cost share changes. So as I mentioned earlier, you have, your medical benefits are the same. Your premium plan pharmacy benefit has no deductible and copays in each of the various tiers. So there's 4 tiers available to your membership based on the types of medications. What you see here in front of you are the standard CMS defined benefit changes. So these are things that Humana and CMS track sort of in the background. For your premium plan members, the only thing that really impacts them is this TRUP, which is the true out-of-pocket cost. So when their true out-of-pocket cost reaches $8,000, which is an increase of $600 from the prior year, then they enter the catastrophic phase. In 2023 currently, once they're in that catastrophic phase, they pay $4.15 for generic medications, $10.35 for brand medications, or 5%. So that can actually, for folks in the higher cost medications, can actually impact them quite significantly from what those copays are. However, for 2024, and this is part of the Inflation Reduction Act impact, that change is going to be 0. So once members hit that catastrophic level, they will get 100% of their drug paid for in that phase of the plan. For your members who are on the essential plan, these things have a little bit more of an impact on them. So that plan is structured to follow this information with one exception, and that is that KPPA did elect in 2020 to hold the deductible amount at $435. So while you see that the deductible in 2023 was $505 and going up to $545 for 2024, as your benefit is structured today, your members would have a $435 deductible. That's what is built into the plan that we have provided the renewal information for today for 2024. And then the initial coverage limit, so the point at which they would fall into the coverage gap, happens at $5,030. However, there is a 25% coinsurance before the coverage gap and after the coverage gap, so no change to the membership there. It would also then occur here when they hit the true out-of-pocket cost at $8,000. After that, there would be zero copayment, 100% coverage for their medications. Questions? All right, that concludes the benefit information that we have to share today. Larry can share an update on the Baptist Health Medical Group contract.
Mr. Powell, do you want us to proceed to this topic, or do you
go ahead.
You want
Yes,
us
sir.
Okay. Well,
Yeah, we'll
happy
do
to
our
give an
discussion
update
when we
here.
get into our rates and all that.
Sure. We wanted to provide a brief update to you. As you all probably know, we are in ongoing contract negotiations with Baptist Health Medical Group. So that is the physicians employed by Baptist Health System. It is not the hospital. So we've been in contract renewal negotiations with them and hopes to reach a new agreement. That agreement is set to expire on September 22nd. So we certainly recognize that there's a good number of KPPA retirees who use Baptist and who would be impacted by this. So we've been in close contact with our network contracting team and are receiving frequent updates. We don't yet have a final new agreement, but we're optimistic that that is going to happen very soon. It's our understanding that Baptist will see our members on a non-par basis, which means for your membership that they would have no financial, that would be no financial impact on them, since the benefits are structured the same for par and non-par providers. So as soon as we have a final update, we'll get that over to Connie and team to share with you all. But it is something that obviously we recognize the importance of, and we're diligently working to get a new agreement executed as quickly as possible.
One quick question there, Larry, if you don't mind. While, as I was looking at it, while the visits and all that remains the same, whether it's in network or out of network, the one issue would be the deductible. That I see Connie shaking her head.
Yeah,
So,
on the medical side, the benefits are identical in network and out of network. So that deductible accrual would basically apply to whether it was a par or a non-par provider. They wouldn't be starting over if they happen to go to a non-par provider. So it really would have no impact on them from a cost share standpoint.
yeah, what I was talking about with in network and out of network is that deductible on the top end. Like right now, it's 5, and I think the out of network is 12. I'm trying to do this from memory. I didn't write it in my notes.
No, I'm sorry,
I don't
Mr. Powell,
have the
it's the
benefit
same.
grid in front of me, but yeah, go ahead, Connie.
I'm sorry, it's 500 for in or out of network. They don't
Okay.
differentiate which is which. And if the doctor takes Medicare allowable, that's what Humana pays. So they won't be billing, above that amount. So it really doesn't have an impact to our retirees as far as cost wise. We may have to communicate a little more closely with Humana and our providers and retirees. So.
I know that's the kind of concerns that I've been getting from the membership. After they received their letter, there was I got quite a few phone calls, text, emails from several people that were concerned. So I wanted to get everything clear on that.
It's upsetting, and it's confusing to the population, to our members, and we recognize that. They're right. Listen, this hospital system's right there in our hometown in Louisville, so it's not. We don't want them to end up becoming a non-par provider. We want them contracted in our network. That's better for everyone, and that's the goal here. So more to come, hopefully, here in the next couple of days.
So it would not be like when we had the issue with Vanderbilt, when it came, they kept extending the contract type of the eligibility to participate under that system, where everything remains the same now. It wouldn't matter whether there was an extension added or not. It's correct.
I've not heard any word of an extension being discussed related to the Baptist negotiations. And with Vanderbilt, that was one where they were non-committal about seeing our members non-par. So this one, at least, we believe they will see our members on a non-par basis if they have a non-par benefit, which certainly your members do. So it's a little different here, but yeah, like I said, more to come in the next several days.
Like I said, I'm trying to raise the curtain a little bit on some of this stuff that when people are comparing the Vandy and Baptist House, and it's clear for them so they're not as concerned. The money is going to cost them out of pocket, and the services they receive are part of it, just to make sure they can see their same doctors, because nobody likes changing doctors.
Right.
Okay, thank you. Go on, Larry. Sorry, I'm getting on my soapbox here.
That's the update on Baptist.
Thank you, sir. Any questions for anybody? All right, thank you.
All right, well then that concludes the material we had to share today. So open to conversation, additional questions about any benefit enhancement opportunities.
All right, thank you very much. Anything else for Humana? Hearing none, we'll move on then.
Mr. Powell, the next in the slide deck is the decision points. I believe that we need to first go to page 43 and have GRS, I believe Michael Reed, discuss the medical only and mirror plan premiums for 2024. If you're
Yes.
Okay.
Good morning. First, I'd like to thank the KPPA and Humana staff for getting us the information we needed quickly this year, as in the past, to get this analysis done. After that analysis, our first, this is the medical only and mirror plan that covers the small group of individuals that qualify for it. After the analysis of the data, we have come to the conclusion that this year the 4.8% increase is needed to cover the medical cost for this group of individuals. Outside of the 4.8%, there's the increase in the ASO and prescription drug portion of the plan that is provided by Humana and just directly reflects what they provided for the premium and essential people. As in previous years, we did not change our methodology on how we rate the plan. It is fully self-funded, and we reflect the data as is, no adjustments. It's all just the experience of the plan is what we rate. We do not look for outside sources to supplement it because it is credible. As the data covers 3 years of past history, that puts the beginning of the pandemic right at the beginning of the experience period. We put less weight on it this year because it was an odd year for medical claims, so that is reflected. But like I said, we put less weight on it to lessen the impact of the up and down that the year had with the medical claims. If you will go ahead and scroll down again. We assumed no plan changes in this analysis for the rate increase. Even though Humana did provide the additional benefit, we just set it aside. If that is opted, it'll be on the back end and we can just add it in. It'll be slightly different just by the way it's paid, but it's a good starting point to add that benefit if you choose to do. So with that increase of 4.8 for the medical only and mirror plan, that leaves last year's premium. The total last year was 180.14, and then this year or next year it'll be 188.73. The essential and the essential and premium, once you include that PDP, that next few lines shows where it raises the increase from 4.8 to 5.9 or down to 4.0, just by the nature of adding the direct cost of those premiums from Humana. Like I said, and then the additional benefits that Humana provided, we did not include, but we only looked at the hearing and vision portion. The deductible, if it was lowered, we did not include in that 39 cents to 8.28 because the nature of being Medicare primary and the KPPA is the secondary, the impact would be different for this plan. So we did not include it in that figure. So if that was elected, that would have to take into account on another consideration. If you have any questions, please let me know. It's straightforward this year with just a minor increase or moderate increase, but that is in line with Humana's.
Okay, I don't hear any questions. Mr. Powell, GRS has also provided some information around, I'm sorry. Sherry, can you go to the next page? Or I think it's 2 pages down. Yes, right here. I just wanted to note that we did not ask GRS to provide a new actuarial equivalence of the Medicare plan with the non-Medicare plan. That was because the plan design hasn't changed since the last time that they did this. Go down 2 more pages, Sherry. Next page. And you can see right here the 2020 Medicare Advantage and Premium PDP. It had the relativity to the 1994 Kentucky Care Standard Plan was 1.089. I just bring that, wanted to point that out, that as benefits enhance on the Medicare Advantage plans, that relativity would just increase.
And what I'd like to point out also to that is that if you compare this to the KEEP plan, this has an actuarial better value than that at 1.089, as opposed to, I think theirs was a 0 or 1.01 or possibly, if I remember correctly, on that. So this is even better value plan than the non-Medicare.
Correct. So then next, Mr. Powell, I know we asked GRS to provide some information around the monthly contribution rates set for the Medicare plans. I know that's the first decision point. Did you want them to just go ahead and discuss their exhibits?
Yes, please, because I think that's relevant to everything else we decide afterwards.
Okay. Janie, are you going to be taking that?
I am.
Okay, great.
I think it's 1 more page down. Yes, perfect. Good morning, everyone. So we're going to talk about the retiree contribution rate for the Medicare plan.
So where we're at today is the retiree contribution rate. So this is the contribution rate that the retirees see is at $252 a month. So as I think Humana just presented, so for 2023, the Medicare Advantage premium that Humana was charging was $89. We just saw that that's going up to $93. And for that plan, and that's about, there's a couple different Medicare plans, but that plan's about 85 to 90% of our membership. So that's kind of the plan we're going to reference here. So there's a bit of a margin there between that. So we're looking at what would happen if we change that retiree contribution rate. So we looked at a bunch of different scenarios here, and we're going to kind of go through those. So on this first exhibit, we looked at what would happen if we change that retiree contribution rate down to the current premium amount. So if we change that retiree contribution down to $89, we looked at a different scenario down on that next page. So what if we didn't go down to the full premium? What if we looked at a 5-year average of premiums? And so we looked at the 2019 to 2023 premiums. Based on a blending of all the plans, that's about $187. And so then if you go to exhibit 3, what if we didn't even bring it down that? What if we just brought it down by $25? So that would be a retiree contribution rate of $227. And then we looked at a fourth option, which is what if we looked at the monthly contribution rate of $100? So you can see this one is between that first and that second option there. So we looked at those options, and so what you can see here is actuarially speaking, when we talk about our valuation results, if we actually go back to that first exhibit there. So actuarially speaking, when we look at this in terms of our valuation results, it does have a pretty minor impact on our valuation. So it does have an increase in our insurance liability across all of the plans. It's fairly small. And the reason for that is that when we're looking at our Medicare retirees, a large portion of those Medicare retirees did retire with 20 years of service. So they are getting their full premium paid by KPPA. So this change would not impact those retirees. So that's why this is having a relatively minor impact on those retirees. And we can see there's also a fairly minor impact on the contribution rate, and that is due to the relatively good funded status of these insurance plans. You can see across all of these exhibits, there's actually no increase in the annual contribution requirement for the K hazardous and the C non-hazardous plan. And again, that's just due to the funded status of those plans right now. So right now, the contribution requirement for those plans are under $0. So that we can't have a negative contribution rate, and that's why there's no impact there. So really what this comes to is this is really a decision for the board. And so what that is so right now what we have is we have on one side where there's that margin between the retiree contribution rate and the premiums. And then that has allowed stability for the retirees. That 252 hasn't changed for several years now. If we look at the other side, we have this first scenario here, this exhibit 1, where if we brought that retiree contribution rate down to the premiums, we wouldn't have that margin there, but we would also see that retiree contribution rate change along with those premium changes each year. So that's really all I have, and then I'll open up to the board for discussion.
I think our discussion will come in this next session when we start looking at what we're going to do.
Okay. Well, to think on it then.
Yeah. Because, I suggested that $100 because that, if, we didn't do any increase into enhancements of the benefits, that should probably stabilize it for 2 years. And then we can look at it again. So, and based on what you looked at, wouldn't you think that would be a fairly accurate statement?
Changing it to $100?
Yes. Do you think it would stabilize the rate for 2 years?
I would say 2 to 3 years.
Yeah. Okay. Yeah.
Can I ask a question about
people
that?
to plan in the future. Yes, sir. Go ahead.
So if the actual premium next year is 93, but we set the contribution at 100, I mean, I don't. There's such a small difference in that. I don't know why we would do that rather than just setting it at the premium.
To build in that, like I said, for that, instead of every year raising it, just give it a chance to be stabilized. But, you know, I'm open for anything. I just wanted to give us extra options to look at here.
I understand that, but I think, I mean, and please, if I'm wrong about this, somebody tell me, but by keeping that rate artificially high, which is what we've done, we've actually ended up charging retirees on the percentage plan more money the last couple of years, right? Because somebody that gets 75% owes 25% of 252 instead of 25% of $89, which it was this year. Aren't I correct about that?
Yes.
Okay. So that strategy really kind of backfired because the rates went down instead of up. Now it helped the trust because we had retirees giving up more of their benefit to pay for their health care, but they paid an artificially high amount. I just don't understand why we wouldn't change it to the premium amount. We vote on this every year. This happens on the non-Medicare side. I mean, it fluctuates all the time. Every single year, there's a different rate. I just don't know why we wouldn't set it at the premium amount. And Danny's got his hand up, and I suspect he's getting ready to tell me.
Yeah, thank you, Keith. The big savings and the big improvement in the funding status in 2022 for the insurance plans occurred because the premium out the door went to Humana in terms of the costs went from 252 to 89. That was the big cost savings. What happens on the member side of keeping the 252? That's a gross amount, and keep in mind, very few people actually pay a full amount. We actually, I don't know if Aaron, or I'm sorry, Aaron has any comments about like the distribution of how the payments are. They have a little bit better data than us, and I thought that would be something, kind of worth discussing.
Well, we did look at it, and we have about 75%, somewhere between 70 and 75% of the people on the Medicare plans have the full 100, the contribution paid. They're not paying anything for their cost. So about roughly 25% are paying something. That could be those who don't have a full 100%. That could be spouses who have access to the group plan that aren't eligible to have anything paid. It can also be those for our dollar contribution individuals that don't have a full amount to cover the premium or cover the monthly contribution rate.
Yeah, so where this comes to, at least when I look at it, you can see the numbers down below. You see the impact on the cost and the liability, and there is some, but really it comes down to policy and optics of where do you want to set the gross premium at? How long do you want to keep it level, or do you anticipate it being level until it catches up? And that could be 0 years. You could set it at the same amount and then have it start moving in lockstep with the actual premium that goes through there. If you have it higher, not only can you keep it stable for a few years, but maybe you can absorb a bigger increase if there's one after. You've got another 1 year guarantee of being at 5%, but you don't know what'll happen after that. So it really comes down to a policy decision, and it's on optics of what the premium is, because you understand that, as Aaron said, 75% have it fully covered. They actually pay zero. Anyway, that concludes my comments.
Thank you, Danny. That answer your question there, Keith?
I mean, it answers my question. I still don't. I just think holding it artificially high of any amount, I don't really understand it, because when the rates go down, like is what's happened the last couple of years, you're actually charging the retirees that have to pay a little more than they would have paid had we set that rate at the actual premium. And I understand that's unusual and that's not going to happen going forward. I know rates are going to go up. I mean, but are we only locked into that 5% increase for one more year? Is that what I heard? Okay,
Yes.
Connie's shaking her head, yes. So then it goes out back out for bid?
No, we've got the extensions. That's just the contracted rate to cap the increase.
Yeah, they just gave us a 2-year, and that would have to be evaluated again if we asked Humana to. They would only give us a 2-year guarantee.
Okay. But I think the point I made about the non-Medicare side, I think stands. I mean, people that have the percentage based and don't get the full amount, I mean, they're accustomed to fluctuating rates because they see that on the non-Medicare side. Do they not, Connie, from year to year?
Yes, sir.
Okay. So I mean, these people are accustomed to that, and we appear, and by the way, those rates fluctuate much more on the non-Medicare side because the numbers are larger. So I don't really understand where, I think we're overcomplicating.
And the plan, and also the plan changes year to year too, of coverage, deductibles, what's included, what's not, with that also.
I just think we ought to every year set it at the premium and just leave it at that and drive on. I don't really get doing anything different.
Okay, anybody else?
I agree with Mr. Piercy.
All right. I think the first thing we probably need to do first is to decide if there will be an enhancement, a benefit enhancement. Can I have your thoughts on enhancing any of the benefits? If so, which one and why?
I'll comment on that, Jerry, if nobody wants to go.
Yeah, I think that going to apply to making a decision about the rates. So that's why I want to tackle that first.
I mean, look, I mean, this isn't going to come as a surprise to anybody. I don't think we're in the benefit business. I think that is reserved for the legislature. I think we already have a situation where, as was just pointed out, the Medicare Advantage plan is already at a significant advantage as opposed to the non-Medicare plan. I think just making that gap even wider is a mistake, and I think it's arguable that it even violates the statute. I understand wanting enhanced benefits. I'm for enhanced benefits, but it's not what we do. And I think from the public comment, it was, suggested that maybe this would be a way to backstop the fact that we haven't had a COLA for years, but that isn't in our purview either. So I just think that, as I've said before, vision, dental, hearing, those aren't things that a single retiree was ever promised when they left employment. And I think adding that on is actually out of the purview of the board. So I would not be, plus the fact that I just pointed out, every $5 the premium goes up, that's an extra 3.3 million plus in spending. We still have one plan that's underfunded. I think this could really be viewed poorly at the PPOB and the legislature at large. So I would not be for benefit enhancements.
Any other comment?
Again, I agree with Mr. Piercy.
Yeah. And do I have a motion to table the enhanced benefits section?
So moved.
Second.
Second?
Second.
Have first and second. Any discussion on that? Favor of tabling, say aye.
Aye.
Opposed? Motion carried. Okay. That took care of that section of it. The next would be the determination of the contribution rate, which plan presented by GRS or any other recommendation from any of the board members for a different rate, or not a rate, but a plan, their contribution rate plan funding. Do we have any decisions there?
Mr. Powell, I'll just say that Sherry just put the decision point slide back up that we had skipped a little earlier. Are you
Right.
speaking to number 2, the medical only and mirror plans?
No. This is just what the GRS just presented as to the
Monthly contribution rate.
the monthly contribution rate that presented by GRS. This is not part of the decision.
Okay.
So we can kind of know where to go from here, which one to go by. I know Keith is in favor of the actual amount. So
Yeah,
I assume you make that motion.
Yeah, I would make a motion. We mirror the premium amount as presented by Humana.
I'll second.
The premium amount is the actual amount that be their cost to us.
$93 and some change.
Whatever, yeah. Well, depending on the plan, but yeah.
Yeah.
Okay. Is that what you understood, Dr. Miller? Okay. So we have a first and a second. Any discussion? Hearing none. The motion is to do the amount that's equal to the premium charged by Humana. All in favor, say aye.
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 Any opposed? Motion carried. All right. Now we can go to our decision points.
Page 42. Yep, thank you, Sherry.
All right. Let me find my notes here again. There they are. All right. The first one is the Medicare Advantage premium plan contribution rate. This will set this rate at $93.35 for the premium plan. So I'll take a motion that we set that as the rate for the premium plan to $93.35.
So moved.
Okay. A second?
Second.
All in favor, say aye.
Aye.
Next would be the essential plan. Oh, no, I missed one. The contribution rate for the hazardous duty spouses and dependents. Motion to set that as the same rate as established by the rates being charged by Humana.
So moved.
Second.
First and a second. Any discussion? All in favor say aye.
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 Opposed? Motion carries. Let's see. The MA premium plan, let's see here, for 2023.
It's $4.07.
7 cents. Yes, essential plan.
So the rate in 2023 was set at $75.56. The premium paid to Humana was $0. So we need to set the premium for this MA essential plan, and the rate that will be paid to Humana in 2024 is $4.07.
Do I have a motion to set that as the rate for 2024 plan year?
Did I understand that right? The premium's going down from $75 to $4? No?
Yes.
Yes?
Yes.
Yes. Okay, sounds like a good deal. I'll make that motion.
Second.
First and second discussion. All right, hearing none. All in favor say aye.
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 Opposed? Ayes have it. All right, that was essential. Next will be for the medical only and mirror. The rate for the medical only is $188.73 as established by Humana. And any discussion, or might want to talk about that or make a motion?
So moved.
Okay. Second?
Second.
Okay. So that is so the motion be established the medical only rate at 188.73. All in favor, say aye.
Aye.
Opposed? Motion carries. Next will be the MA mirror plan. The essential plan rate, I'm going to roll these both in together, is 228.98 as essential, and the premium mirror is 328.11. Any discussion or thoughts, or anyone want to make a motion?
Is this 2A on page 42? Is that what we're talking about?
Yes.
Yes. Okay. I'll make that motion.
Second.
Have a first and a second. Any discussion? All in favor, say aye.
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 Opposed? Motion carried. Then I should have wrapped that in the other one, but to allow enrollment for non-Part B and its exceptions. Excuse me, just got choked there for a second. Somebody be willing to make a motion for that?
So moved.
Or is there any questions? Okay, we have a motion and a second. Do we have a second?
Second.
Thank you, sir. I have motion and second. Discussion. All in favor, say aye.
Aye.
Thank you. The next would be the default plan. For plan year 2023, it was medical only plan. This is like all the other default plans. Is there any objection or somebody wish to establish a different default plan, or is the medical only acceptable?
I'll make that motion to just continue the medical only plan.
All right,
As
thank
default.
you, sir.
Second.
And I have first and second. Any discussion? All in favor, say aye.
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 Opposed? Motion carried. I think that all. I think that's all our decisions we need to be making on this. Oh, yes, Miss Connie.
I just want to point out that I have an answer for Dr. Miller's question. They do not consider vaping as a part of the tobacco usage fee because it's not tobacco, it's nicotine. Now, Mr. Powell and I can question the board we go to every month to see if they feel like that definition needs to be changed, Dr. Miller. I appreciate your recommendations. Thank you.
Thank you for following up so quick. I just, some of the health issues that we're seeing along with vaping is, that's the concern, right? What's the medical cost to that so thank you for checking into that.
You're welcome.
Appreciate that, Ms. Patty John. Really on the spot there for it. All right. What else we have here? I think that took care of our agenda items. Anybody else have anything they wish to add? Was there any other business they wish to discuss? Hearing none, I think we did pretty good. We had 1 hour and 39 minutes to cover all this material. I want to thank the staff and the board members for participating, sharing your thoughts in this very complex issue. When we have to do every year, but it's good to know that everybody's well informed and cognizant of the issues of trying to balance between the funding of the system and the benefits to our membership. So hearing no other business or discussions, I'll adjourn this meeting of the Joint Healthcare Committee. Thank you.